This is Randy Schell. I'm making a podcast entitled Anesthesiology Gaps in Knowledge 2016, with apologies to Homer Simpson here. This Gaps in Knowledge podcast is part of the University of Kentucky Department of Anesthesiology Didactics. Well, what are gaps in knowledge? Gaps in knowledge are questions that a majority of residents answered incorrectly on the annual in-training examination. And the American Board of Anesthesia publishes the list of topics each year, usually somewhere around 10 to 15 of these gaps. We will be going over each of these gaps for the year 2016. The first gap from 2016 is in orange here. When viewed on a chest x-ray, the correct position of the tip of a central venous catheter placed via the right internal jugular vein is above the level of the carina. That's a true statement, and a question was built around that. The concept that in the far right you can see a tip of a central venous catheter, and you can also see the carina, and the tip of that central venous catheter is above the level of the carina, and that is the correct place of where it should be ideally. The tip should not only lie within the superior vena cava above the level of the carina, but above the junction with the right atrium, and also parallel to the vessel wall. If it's not parallel to the vessel wall, it could rub against that wall and potentially erode through it. If the catheter is sitting way up high, it could erode through the vessel. If it's sitting way low, it could sit in the atrium and bang against the wall and cause dysrhythmias. It could even go into the coronary sinus or damage the tricuspid valve or pierce the right atrium. And since the right atrium is below the level of the pericardial reflection, which is actually at about the level of the carina, a hole at that level would allow blood to go into the pericardium, and pericardial tamponade could result. A chest x-ray with an overlay of the anatomy is shown here, and the point that I would like to make is that the carina and the pericardial reflection, the anatomic orientation is that the carina is above the level of the pericardial reflection. It's approximately at it, but if your CV central venous catheter tip happened to be below the level of the carina, that would be considered too low, and the tip position should be above the level of the carina. Let's move on to our gap number 2, which is as minute ventilation increases linearly in a mechanically ventilated patient, the CO2 level decreases asymptotically with a more rapid decline initially. Now that sounds pretty complicated, but let's look at it graphically on the far right. And basically what it's saying, as you increase alveolar ventilation, the CO2 goes down. Well, that's obvious, but it's not a linear relationship. And in fact, if you look at the point where 5 liters is represented on the x-axis, and that is 5 liters of alveolar ventilation, and trace it up on the graph of 200 mils per minute of CO2 being produced each minute, which is about average, you can see that the CO2 is approximately 40 in a normal patient. All you have to do, though, is go down just a little bit on your alveolar ventilation, and there's a dramatic increase in the CO2. So as you go up on alveolar ventilation in that low range, if you were at 2 to 4 liters and went up to 5, 6, 7, 8 liters, you can see there's a dramatic drop in alveolar and arterial CO2 that levels out, and that as you go up even to 10 and 15 and to 20 liters per minute, there's not a huge drop in CO2 after that. And this is the point that the question was built around, this concept. There's some clinical applications that even if you give a small amount of a sedative opioid to a hypercapnic patient, this could be very dangerous. For example, if a patient had a CO2 of about 60 and you gave them a little bit of opioid and their alveolar ventilation went down just a little bit, 500 mils or a liter, you can see that there would be a dramatic rise in their CO2. Arterial hypercapnia, the cause of it is either you're not ventilating the patient enough, alveolar ventilation, or there's too much of total ventilation ending up as dead space. And normal dead space to tidal volume is approximately 30%. For example, anatomic dead space is approximately 150 mils of your trachea and bronchi going down to your gas exchanging alveoli. And if a tidal volume was 450, the ratio of 150 over 450 is the classic 1/3. And as it gets higher and higher, more of your alveolar ventilation going to the dead space, you're going to get rid of CO2 less and less efficiently. The third concept that was missed by a large number of residents was when a patient develops a generalized seizure during hyperbaric oxygen therapy, the most appropriate initial treatment is to discontinue the inhaled oxygen. This concept requires you to understand what's going on during hyperbaric oxygen therapy, which is used for non-healing wounds, for cyanide toxicity, for carbon monoxide toxicity, the treatment of such. But a patient can go into a chamber where increasing atmospheric pressure is supplied along with supplemental oxygen and increases tissue oxygen levels. Well, if a patient's in one of those hyperbaric chambers and gets oxygen toxicity to the central nervous system, which exhibits as a seizure, the treatment is to reduce the inspired oxygen. Don't decompress the chamber. If the chamber was several atmospheres or more, and you decompress it, let's say from 3 atmospheres down to 1 atmosphere rapidly, the lung, which was under pressure, and we can think of it as being kind of small, suddenly the pressure outside goes down dramatically. If the glottis was closed and the patient wasn't exhaling normally during a seizure, the lungs would expand rapidly and you could get barotrauma. This would be like decompressing from a scuba dive ascending very rapidly against a closed glottis and having a lung potentially blow barotrauma. These hyperbaric oxygen-induced seizures rarely have any sequela, and you can actually continue hyperbaric oxygen therapy in these patients even if they've had a seizure before related to the high inspired oxygen. And they're also not more common in patients with a pre-existing seizure disorder. There's some other problems with oxygen toxicity, and not just the central nervous system, but the lungs, which a patient will often exhibit tracheobronchial irritation, cough, and complain of burning chest pain, may even have ARDS-like picture. And the visual system is affected with narrowing of the visual fields and even some change in refraction, such as myopia. The fourth gap in 2016 was that hyperglycemia should be avoided in patients with hyperkalemic, that is hypokalemic, low potassium, periodic paralysis. Periodic paralysis is a disorder where certain things like changes in potassium can result in muscle weakness, paralysis of muscles. In the hypokalemic form, low potassium causes this periodic paralysis. So triggers of periodic paralysis in patients with the hypokalemic form include the following. Exercise. Well, why exercise? Because as you exercise, catecholamines go up and they drive potassium into the cell. Glucose infusions is a classic one. If you start large amounts of glucose infusing into a patient, their insulin levels go up, drive the potassium as well as the sugar into the cell. Stress, high catecholamines again. Pregnancy, hypothermia, which is common as a trigger to both hyper and the hypokalemic forms of paralysis. High carbohydrate meals, same idea as the glucose infusion. Insulin levels go up, glucose goes into the cell as well as potassium, and the low potassium results potentially in periodic paralysis. Infusions of beta agonist drugs, things like epinephrine, dobutamine, things that with beta-1 effects can, again, drive potassium into the cell. This hypokalemic periodic paralysis can be associated with cardiac dysrhythmias and electrocardiographic signs of hypokalemia, including flattening of the T waves. In these patients with hypokalemic periodic paralysis, succinylcholine and non-depolarizing neuromuscular blocking agents are okay, and the abnormality appears to be calcium channel, occasionally sodium channel in some patients, but classically the calcium channel is the problem. Gap number 5 is that hyperthyroidism will increase beta-1 adrenergic receptor density in cardiac muscle. And in the top right, you can see a graphic showing epinephrine binding to the beta adrenergic receptor. There's a G protein mediated messenger, and eventually cyclic AMP goes up inside the cell, and eventually calcium goes up inside the cell also. There is upregulation of these beta receptors with hyperthyroidism. So if a patient is hyperthyroid and has more beta receptors, you would expect a bigger response to the same dose of a beta agonist. So if you gave ephedrine to a patient who's hyperthyroid, you may have an exaggerated sympathetic response. Beta blockers also cause upregulation of the beta receptor. If you cover the beta receptor with a beta blocker, I like to think of the cell membrane going, what's going on here? I'll grow some more beta receptors, and it does so. So upregulation. Exposure to beta agonists, infusions of epinephrine, dobutamine, etc., can cause downregulation of the beta receptors. Congestive heart failure, where high circulating catecholamines are present, and cardiopulmonary bypass, which is a high stress situation with high catecholamines, all are associated with downregulation. Gap number 6 was a regional anesthesia question, and the concept is that when placing a femoral nerve block using a nerve stimulator, that contraction of the sartorius muscle indicates that the needle needs to be moved deeper and more laterally. So if you look at the picture on the top right showing the anatomy of the femoral area, you can see the inguinal ligament in number 5. You can see the nerve at 2, artery at 1, vein at 3, nerve, artery, vein in that order going laterally to medially. And then the sartorius muscle is number 6 here, going from the lateral to the medial aspect of the thigh. As the needle starts to head down towards the femoral nerve, the anterior branch of the femoral nerve is usually encountered with the first pass, and this can stimulate the sartorius such that you get contraction of the lower medial thigh. What you really want, though, is contraction of the patella, or the classic patellar snap associated with the large muscles of the anterior thigh being stimulated. So what you would do then is move that needle back, move it deeper, and redirect it laterally also, because when you go deeper and laterally, there's branches that come off that supply the muscles of the anterior thigh, and then you get your patellar snap. So knowing the anatomy of the inguinal area and what happens with stimulation, realizing that superficial stimulation of the femoral nerve may and contraction of the sartorius is not what you want, you would move that needle deeper and more laterally to get the branch that comes off to the anterior thigh muscles and get the patellar snap. Remember that the femoral nerve innervates multiple muscles, including the iliopsoas, sartorius, quadriceps femoris group of muscles. It moves the hip and the knee, so it's motor above the knee, and it has some sensory components below the knee, but mainly the anterior and lateral thigh sensation, and the medial aspect of the leg and the foot is the continuation of the saphenous nerve. So blockade of the femoral nerve would involve motor blockade of those muscles above the knee and sensory above the knee with some sensory going down the medial aspect of the leg to the foot. Now gap number 7 was obesity being a risk factor for postoperative ischemic optic neuropathy after spinal fusion with patients in the prone position. The risks of ION, or ischemic optic neuropathy, appear to be aging, male patients, large transfusion requirements, and obesity is one of those. And there's a recent review paper by Rubin et al. In Anesthesiology 2016 that would be a good one to review on this topic. Blindness after a spinal fusion occurs in 1 to 10 out of 10,000 patients, so not very common, but it's most common cause of postoperative vision loss, that is ischemic optic neuropathy, after non-ocular surgery. So non-eye surgery, specifically spine fusion and cardiac surgery, is another risk factor for postoperative vision loss. Well, this ION, ischemic optic neuropathy, can be both anterior or posterior And it's the anterior ischemic optic neuropathy that you can, on fundal exam, see changes to the posterior eye. And the patient will wake up with painless vision loss in both AION and PION. But if you look at the optic disc, the anterior has changes to the optic disc, while the posterior is retrobulbar behind it, and so the fundoscopic exam is normal. The take-home point from this is that ischemic optic neuropathy occurs after spinal fusion with risk factors including obesity. And one of the take-home points is that AION will have an abnormal fundoscopic exam, while PION will have a normal fundoscopic exam. Gap number 8 is that general anesthesia with inhaled sevoflurane will result in peripheral vasodilation, blunting the skin's normal vasoconstrictive response to hypothermia. And the far right shows desflurane concentration on the x-axis versus the threshold in degrees centigrade for several things. Green being shivering threshold, red being vasoconstriction threshold, and the blue being sweating. And you can see that inhaled volatile anesthetics, DES being the example here, as the desflurane concentration goes up, the shivering threshold goes down, the vasoconstriction threshold goes down, meaning that these normal body ways of retaining heat, vasoconstricting and shivering, are inhibited. And they're inhibited more as the concentration of the inhaled anesthetic goes up. Sevoflurane and desflurane are vasodilators, and the blood vessels normally would vasoconstrict when you get cold, but in the presence of sevoflurane and des, vasodilate and lose more heat. So general anesthetics reduce the thresholds for vasoconstriction and shivering, and as a patient's recovering from either sevo or desflurane, there will be a decreased end-tidal concentration of sevo or des, and there will be improved vasoconstriction and less heat loss as the inhaled anesthetic is blown off. Remember that the initial heat loss that occurs in the operating room is redistribution. Remember that periphery is cold and the core is warm, and under general anesthesia there can be redistribution, and the initial drop in temperature over the first 30 to 60 minutes is this redistribution rather than loss to radiation, which is what occurs after that time as the number one mode of heat loss, where radiation heat loss exceeds metabolic heat production, and one of the reasons that we keep the room cold, or keep the room warm, that is, to preserve heat. Now, if you look at the top right, L-fentanyl, dexmedetomidine at the bottom left, and propofol, examples of what these intravenous drugs do to thresholds of vasoconstriction, sweating, and shivering. And you can see that propofol has a pretty big effect on it, dexmedetomidine a little bit, and L-fentanyl a little bit, but not as much as desflurane and propofol. Let's move on to the ninth gap, and that is that occlusion of the gas outlet ports in the oxygenator of the cardiopulmonary bypass machine can result in a gas embolism. To understand this, we need to look at the oxygenator and see how it works. A schematic is shown at the right with fresh gas coming in on one side of a membrane and blood flowing on the other side countercurrently, and gases are exchanged across that membrane oxygenator. But the fresh gas that comes in has to exit somewhere, and it exits out the exhaust gas port. Occlusion of this exhaust gas port with, at the same time, gases pouring in, oxygen, air pouring in, can force gases into those membranes, across those membranes, into the blood, and cause embolization. So we don't want this exhaust gas port to be occluded in any way. So continued inflow of fresh gas without exit can result in bubbling out of the gas into the blood, creating an air embolism. And that concept was one that was missed by most taking the in-training exam in 2016. The next gap was that the ASA physical status classification system was originally developed for facilitating comparison of anesthetic data, and it was not devised to stratify operative risk. When the scale was proposed in 1941, it was to address the patient's preoperative state only, not the surgical procedure or other factors that could influence surgical outcome. The hope was that anesthesiologists across the country would adopt common terminology and be able to make some statistical comparisons of morbidity and mortality and outcome comparisons to the operative procedure and the patient's preoperative condition. So it was not developed as a method of stratifying operative risk, but for facilitating comparison of anesthetic data between caregivers. Now, the ASA classification is shown at the right, which you should be well aware of. Several things to point out. One, ASA 3 patient has severe systemic disease, as opposed to ASA 4. Yes, they have severe systemic disease, but it's also a constant threat to life. And that could be a patient with ongoing myocardial ischemia, recent MI, cerebral vascular accident, TIA, cardiac stenting, etc. ASA 5 is the patient who's not expected to survive without the operation. This could be someone who's brought in with a ruptured AAA or thoracic aneurysm or bleed into the head. And ASA 6 is a patient who has been declared brain dead and whose organs are being removed for transplant. Let's move to gap number 11, the last one now, and that is during one lung ventilation, ACE inhibitors can attenuate hypoxic pulmonary vasoconstriction. Hypoxic pulmonary vasoconstriction is vasoconstriction of the pulmonary arterioles in response to alveolar hypoxia. And on the graphic at the far right shows regional hypoxia first and generalized hypoxia in B. So let's look at the regional hypoxia first. If there's an alveolus that does not contain much oxygen inside, P big AO2 is low. The blood that goes by that, you don't want a lot to go by, and so HPV, if it's working well, causes vasoconstriction. Hypoxia causes the vasoconstriction of the blood vessels around it, minimizing VQ mismatch in this hypoxic lung and shunting blood to areas that are better oxygenated. This HPV effect, which can be regional, or in the case of generalized hypoxia, that is, where you're climbing Mount Everest and at the top you're going to have hypoxia in all your alveolar segments, you can have generalized vasoconstriction and pulmonary hypertension and right heart failure. But factors that impair this normal HPV do so by causing pulmonary vasodilation or vasoconstriction in messing with that set point of where HPV should be. And agents that attenuate HPV are drugs that cause vasodilation, nitroglycerin being a great example, nitroprusside being another one. Our inhaled volatile agents to some extent attenuate HPV. Inhaled nitric oxide, phosphodiesterase inhibitors, drugs like sildenafil. But the one that was on the gap in knowledge was ACE inhibitors, and also ARBs could be included in this. These vasodilating agents attenuate HPV. Don't forget that vasoconstrictors attenuate HPV too. They can change the set point of blood flow at vasoconstricting areas that have good oxygen in them in the alveolus and send blood to other areas, causing more VQ mismatch. IV anesthetics have little effect on HPV as compared to these vasodilators, vasoconstrictors, and the volatile inhaled anesthetics. This ends the Gaps in Knowledge 2016. Listen to and view the Gaps in Knowledge 2015 and 14, which are on separate podcasts if you so desire, and I hope you have a great day.